Welcome to Grand Rounds for July 2026. Today we're going to be talking about predicting mobility, so the prognosis of ambulation in infants with cerebral palsy. Today we have Dr. Kristen Carnell talking to us about this topic. She earned a bachelor's degree in health sciences with minors in exercise physiology, ethics, psychology, and women and children in the community from St. Francis University. She then earned a Doctor of Physical Therapy degree from St. Francis University, and then completed her residency training in pediatric physical therapy, also at St. Francis University. And she is board certified in pediatric physical therapy. Dr. Carnell has certifications in dynamic movement intervention and the general movement assessment. She currently serves as secretary for the Pediatric Special Interest Group for APTA Pennsylvania. As some reminders, make sure that you mute yourself if you're online until the end when we have questions. Also, make sure that you sign in either with the QR code or with the code on the left. And I did copy it into the chat so that you can access it if you missed this first slide. If you're watching the recorded version, you're already in, so excellent. And at the end, make sure you take the quiz and also complete the course evaluation so you get the appropriate CE or CME credit for this course. This is our credit information, our statement of need, and it's targeted for all providers. This is St. Luke's designation statement, and the planners and presenters have nothing to disclose. So without further ado, I will turn it over to Dr. Carnell.
So for our learning objectives today, you, by the end of this presentation, will be able to understand the causes of abnormal development in children. Oh,
sorry, one thing I gotta fix here.
Just kidding.
My apologies, everybody. And now we're good.
Okay. So by the end of this presentation, you will be able to understand the causes of abnormal development in children with CP, classify CP by the type and GMFCS level, define typical and atypical general movement patterns, and discuss factors relating to predicting gross motor abilities in children with cerebral palsy. One of the most frequent questions that you may get when a child is diagnosed with CP is when, if they will walk. So this presentation is going to try to explain some prognostic factors in ambulation for children with cerebral palsy. CP refers to a group of disorders.
My apologies. Apparently it's not sharing.
What?
Now we're good. My apologies, everybody.
Okay. You good?
Yep.
Okay. Cerebral palsy refers to a group of disorders in the development of posture and motor control occurring because of a non-progressive lesion in the developing nervous system. The exact cause of cerebral palsy is often unknown, but it's likely multifactorial. The cause is understood to be a brain injury or brain malformation occurring before, during, or immediately after birth. Risk factors for cerebral palsy can be broken down into biological and environmental risk factors, with biological risk factors being further categorized as prenatal, perinatal, and postnatal. Prenatal would include any abnormal development, including disturbance of brain cell migration or poor myelination of the developing nerve cells. Perinatal would include any abnormal development, including disturbance of brain cell. Nope, that was the wrong one. Sorry. Perinatal includes events occurring during the birthing process, so anything that would cause brain cell death. And then postnatal refers to non-functioning synapses during trauma, infection, or asphyxia. Environmental factors would include prematurity, atypical growth, and multiple births. Some other factors may be difficult to determine in retrospect and can include things like intrauterine infection during birth, antepartum hemorrhage, and potentially a tight nuchal cord. Oh. There we go. Okay. Cerebral palsy can be classified by either movement differences or topographical distribution. Movement differences would describe the location of brain damage, while topographical distribution describes the affected areas. Spastic cerebral palsy features spasticity and exaggerated reflexes due to the insult on the motor cortex or cortical sensory motor areas. Dyskinetic CP affects the basal ganglia and thalamus and results in key characteristics of atypical patterns of posture and involuntary recurring movements. Dyskinetic CP can be further categorized as dystonic or athetoic. And then ataxic CP is damage to the cerebellum, which results in ataxia. Diplegic CP would indicate that bilateral lower extremities are affected more than the upper extremities. Hemiplegia is a result of the upper extremity and lower extremity on the same side, affected more than the contralateral limbs. And quadriplegia would indicate that all limbs are affected. Those with cerebral palsy are also classified using the gross motor function classification system, or a GMFCS level. Oh no. So these GMFCS levels describe those with cerebral palsy based on their gross motor abilities and their need for assistance. Gross motor functions that are emphasized would be walking, sitting, and wheelchair navigation. It is understood that levels will vary from 1 through 5, with a level 1 indicating the least amount of restrictions and a level 5 being the most impaired in gross motor capabilities. The patient with a GMFCS level 1 can walk indoors and outdoors without restriction. They can climb stairs with no handrail support, and they can run and jump. A GMFCS 1, however, would have some level of impairment, most likely in balance, coordination, or decreased speed compared to their age-matched peers. A GMFCS level 2 would indicate that the child can walk indoors and outdoors. They can climb stairs with a railing support and will most likely have difficulty navigating uneven surfaces, inclines, and walking within crowds. Running and jumping are also difficult for a GMFCS level 2 patient. A GMFCS level 3 will walk with an assistive device indoors and outdoors. They may be able to climb stairs with railing support, and they will independently propel a manual wheelchair. A patient with GMFCS level 4 will severely be limited in walking ability, even with assistive devices, and will most likely require assistance when walking. This patient would utilize a wheelchair primarily, and they may participate in standing transfers. And finally, a GMFCS level 5 will experience impairment in all the areas. They cannot sit independently, they cannot walk, they cannot stand. In terms of this presentation and the discussion of prognosis for ambulation, a GMFCS level 3 or less would provide the best prognosis for ambulation based on the descriptions we just went over. A study by Palsino et al. Aimed to describe how the probability of walking, wheeled mobility, and assisted mobility changed with environmental setting and age in children and adolescents with cerebral palsy. Results of this study provide evidence that age and environmental settings influence the method of mobility in children with CP. This is important to note, though it's not necessarily related to prognosis of ambulation, but it can provide potential insights into motivations for ambulation. So for example, if you're looking at the image from the article, if you're looking at the level 2, 3, and 4 within the school setting, the majority will walk independently or walk with assisted mobility. Most of them will try to avoid wheeled mobility, such as wheelchairs or power wheelchairs, because they don't want to be seen in a wheelchair in school. So different motivators depending on the settings. This type of motivation and information is important to consider when discussing the GMFCS levels and environmental influences or motivators that can affect walking later on. In relation to the GMFCS levels, we have what we call gross motor development curves. These are used to describe patterns of gross motor development within the GMFCS levels. They can be used to estimate future motor capabilities to an extent and the potential level of independence later on. A study by Yu Young Park found that a child's determined GMFCS level around age 12 is highly predictive of their adult motor function. The same study found that there is a level of stability within the classification levels, meaning that the proportion of children whose level did not change was higher than those who did. For those who were able to change their levels, the change was higher between the ages of 2 and 4 years old. So this would suggest that there is a need to classify function repeatedly over time, especially in those younger than 4. The information provided by the study also emphasizes the importance of earlier intervention to optimize the developmental potential. Again, in terms of this presentation, we would like to see a GMFCS level 3 or less to provide the best prognosis for ambulation. If there is not much change in the level past 4 years old, we could most likely assume that someone at 4 with a level 3 GMFCS level would have good prognosis for ambulation in the future, barring that, range of motion, spasticity, strength, and balance are well managed. Early diagnostic tools and screenings are important in assisting with earlier intervention to optimize developmental potential. Some diagnostic tools available in some capacity at St. Luke's include imaging, most likely an MRI, the General Movement Assessment, or the GMA, the Hammersmith Infant Neurologic Exam, or the HINE, and the Test of Infant Motor Performance, or the TIMP. Several studies have confirmed that the best predictive validity for cerebral palsy would be a combination of an MRI, the GMA, and the HINE in those who are younger than 5 months old. The same study suggests that a combination of an MRI, the HINE, and some type of developmental assessment such as the P-body has the best predictive validity for a CP diagnosis in those that are older than 5 months. The GMA will be the primary focus for the purpose of discussing prognosis of ambulation. The GMA can be used for infants 20 weeks corrected age and younger, and it is used to identify neurologic issues which can lead to developmental disability. A study by John et al. Found that a predictive ability of the GMA is actually greater than that of a cranial ultrasound, as well as a neurologic assessment. The same study found that the predictive ability of the GMA is comparable to an MRI. The GMA has a sensitivity of up to 98% and a specificity of up to 96%, according to the study by Spieler et al. The GMA focuses on analyzing and tracking the trajectory of the quality of general movement patterns. So general movement patterns are movement patterns involving the whole body, and they're created by central pattern generators. These movements are seen in infants as early as 9 weeks post-menstrual age and will continue to be seen until the infant develops voluntary movement later on. So, the the general movements that the GMA will assess can be broken into phases of writhing and fidgety movement, with writhing movements occurring for a longer period of time. Typical general movements have components that make the movement fluent and elegant is what they kind of describe it as. They create an impression of complexity and variability. The variability that you will see in general movements is a sign of typical development and a good neurologic system, because variable movement leads to cortical learning. Absence of core characteristics like the adequate complexity, the variability, any fluency of the normal general movements are associated with adverse neurologic outcomes like cerebral palsy or other diagnoses like developmental coordination disorder. So writhing movement is seen as early as 9 weeks post-menstrual age, and it continues to be seen during the first 2 months post-term age. These movements are defined as small to moderate amplitude, slow to moderate speed, and they are elliptical in form, so they kind of have like a circular motion to it. Writhing, you typically see at all limbs, mostly at proximal joints, so shoulders and hips, but you will also see it at as distal as wrists and ankles. Writhing should be variable, and there should be no consistent pattern. So when you're watching writhing movements, you should not be able to predict the next movement in the sequence, or else that's not the typical variability that you would want to see. Fidgety movement is multiplanar, and it is consistent of small amplitude, moderate speed movements that are variable in acceleration. The fidgety phase begins around 6 to 9 weeks post-term and will last until the child is developing voluntary anti-gravity movement, so around 15 to 20 weeks post-term. According to the studies completed by Prechtel et al. And Boswell et al., fidgety movement is considered the best clinical test for early prediction of cerebral palsy. However, writhing is helpful when tracking trajectory to predict prognosis for gross motor function. The study by John et al. Suggests that abnormal writhing patterns that normalize by fidgety stages of development would indicate a normal neurodevelopmental outcome. This is because normal fidgety would indicate normalization of movement with brain maturation, even with abnormal writhing movements early on. So let's see if it works. So this video is a great example of fidgety movement, and this is what you would kind of want to see in infants during this phase. So in the video, you can see the small fidgets or bounce-like movements. You can see them the most in this video at bilateral wrists, bilateral ankles, and you can even see it in the head and neck. Fidgety movement is not intentional movement, so there is some intentional movement and anti-gravity movement developing in this infant in this video, but you're more looking at the background movement. So the easiest way to see fidgety is if we replay the video, if you stop and start the video, so that initial like bounce to them when you first start, that's the fidgety movement that you're looking for. Fidgety movements would indicate a normal developing nervous system is likely for this child, according to the studies by Prechtel et al. And Boswell et al. Alrighty. So there are 5 abnormal general movements that Prechtel's GMA exam does go into detail for. Abnormal movements can be used to assist in predicting prognosis and diagnostic purposes. So poor repertoire, cramped synchronous movement, and chaotic movement are all abnormal forms of writhing. So these abnormal movement patterns do have some diagnostic ability, but mostly they're used to track trajectory and determine prognosis for gross motor function later on. Multiple studies have suggested that different movements in the writhing, so the poor repertoire and cramp synchronous, are the ones that you are most concerned about seeing and need to monitor closely. Abnormal fidgety and absent fidgety are abnormal forms of the fidgety movement, and they have more diagnostic ability than the abnormal writhing movement, because fidgety movement, like I said earlier in the presentation, is the most predictive phases for a cerebral palsy diagnosis. Poor repertoire is monotonous sequences of writhing. So these children do present with writhing. However, it lacks the complexity and variability that you would typically see in a normal writhing movement. According to findings by Prechtel et al. And Ferrari et al., poor repertoire is common in preterm infants, especially those who are considered extremely low birth weight, so anyone less than 100 grams at birth. Articles by Spieler et al. And Prechtel et al. Suggest that these movements can be good later on. They could have good prognosis, or they could have poor prognosis, depending on what trajectory is seen later on. And I will kind of discuss trajectory tracking here upcoming in a few slides. But poor repertoire movement noted early on would need to be monitored closely to better track the trajectory and determine the prognosis. Okay, cramp synchronous movement appears rigid, and it lacks the normal fluent character that a typical writhing would have. For cramp synchronous, all limbs and the trunk will contract almost simultaneously, creating that rigid appearance. The type of abnormal writhing that cramp synchronous shows lacks traditional rotational components or elliptical movements that you also see in normal writhing movement. According to Prechtel et al., when assessing for general movements, cramp synchronized would always develop from poor repertoire, which is why you need to track the trajectory. Cramp synchronous is not what you would typically see post-birth immediately, just because you need the time for the brain to get over the shock of the initial insult. So initially, what you might see is poor repertoire that transitions into cramp synchronous. So you just, again, need to track the trajectory and determine when the cramp synchronous started, when it transitioned from poor repertoire, and things like that, in order to better determine the prognosis for gross motor function later on. So this video is of cramp synchronized movement. So in So in this video, you can see the rigid contraction and the stiffness that would indicate a cramp synchronized pattern of movement. There's no elliptical movement. You did not see any of like the rotational. You saw them contract into that stiffness, and they might have kind of weight shifted to one side just because the one side contracted more than the other. This movement does lack the elegance that you would see in typical writhing because it does not have that elliptical form. For those of us who work with children with reflux and seizure disorders, some infants with reflux and seizure disorders can present similarly to the cramp synchronized movement. Studies by Prechtel et al. Suggest that we would need to see the cramp synchronized movement at least twice several days apart to differentiate from other causes. The study also suggests that inconsistent or non-persistent cramp synchronized movement would likely be caused by reflux or a seizure disorder, whereas a more consistent cramp synchronized movement is a strong marker for spastic cerebral palsy, according to the study by Spieler et al. Chaotic movement is basically what it sounds like. This is very rarely seen. So chaotic movement has large amplitude movements and it occurs in all limbs. There's no fluency whatsoever. It's just a chaotic order. There's no elegance to it. It's just kind of all over the place. So these infants that present with chaotic infants or chaotic movement, the movement is very abrupt. It lacks the smoothness that like a typical writhing would start and end. This type of movement is transient. It does not last for more than a few days. According to Prechtel, chaotic movement typically indicates an underlying medical issue, or it can start the transition towards cramp synchronized movement. If it is due to an underlying medical issue, once the medical issue is resolved, the chaotic movement does also resolve. Abnormal fidgety are children that present with the fidgety movement, but this movement is exaggerated compared to the normal fidgety movement that we saw earlier in the video. They excessively fidget, and you can really see the excessive fidgets proximally, which almost looks like a tremor when you're watching a video. The movement that you see is sometimes described as the child being like a puppet on a string. It's just very large compared to the small bounce-like movements that a typical fidgety movement would be. Abnormal fidgety, as we'll discuss later, is not necessarily associated with cerebral palsy as much as the absent fidgety will be. It could indicate some other underlying minor neurodevelopmental diagnoses, and that tends to be more likely with abnormal fidgety. Absent fidgety would be most indicative of cerebral palsy. So this type of movement means that fidgety movement was never observed between 6 to 20 weeks post-term. The child never developed that absent or that fidgety movement, and they lack that background movement that you would typically see during those phases. Prechtel et al. Found that all of those absent fidgety movements will likely be diagnosed later with CP. That is the likely trajectory if you have absent fidgety. A study by Stowen et al. Found that among children with cerebral palsy, those who present with sporadic or intermittent fidgety movement had significantly better gross motor outcomes than those with completely absent fidgety movement. The same study found that sporadic fidgety movement did not necessarily indicate milder forms of cerebral palsy, but GMSCS level 1s were higher in those with sporadic compared to absent fidgety. They just couldn't conclude this. The number was not found statistically significant, but it can be something that you can consider when evaluating your patient's potential function. So, trajectory tracking. So, a study by Spieler et al. Created a trajectory tracking depending on the infant's GMA findings. For those with normal writhing, they most likely will develop normal fidgety and they have normal developmental outcomes. The study also suggests that a majority of poor repertoire infants will go on to develop normal fidgety movement, indicating maturation of the developing nervous system, and therefore will have a normal outcome. Some with poor repertoire will develop either absent fidgety or abnormal fidgety, and then will go on to either develop a minor neurologic disorder or cerebral palsy, depending on which is seen. The same study suggests that the majority of infants with cramp synchronized movement will lack the fidgety movement, making the cerebral palsy diagnosis the most likely. Following this type of trajectory tracking is helpful for diagnosis, but certain components of the trajectory can also suggest prognosis for gross motor function later on. This is especially true when you combine it with other objective measures. So the study by Spieler et al. Found that absent fidgety movement with abnormal neurologic exam would suggest a likely diagnosis of bilateral spastic cerebral palsy, while intermittent fidgety movement with asymmetrical segmental movements would likely lead to a hemiplegia diagnosis. So this type of information that you can gather from the trajectory tracking can assist when determining prognosis to an extent, because as many of us will see clinically, quadriplegia diagnosis would indicate less likelihood of independent ambulation. The study by Ferrari et al. Aimed to determine whether specific abnormalities in general movement can predict cerebral palsy and the severity later for gross motor impairments in preterm infants. For those with consistent normal general movements and transient poor repertoire, normal outcomes were likely seen. For those with consistent poor repertoire and transient cramp synchronized movement, you might see mild motor impairment. Moderate to severe motor impairment was seen in those with predominant cramp synchronized movement and consistent cramp synchronous movement, further supporting that the more dominant the cramp synchronized movement in terms of the movement pattern that we see, the worse the outcome will likely be. This could also suggest that those with predominant to consistent cramp synchronous movement would have a poorer prognosis when discussing ambulation. The same study suggested there is a relationship between the age of appearance of the predominant cramp synchronous or consistent cramp synchronized movement and the severity of impairment. So the study found that the earlier the cramp synchronized quality general movements appear, the worse the outcome is. This was proved to be statistically significant in the study, and then another study also found that they kind of defined the weeks that you're looking at. So the other study had said that if you notice persistent or consistent cramp synchronized movement at 43 weeks post-menstrual age or later, you will most likely move on to see a GMFCS level 1 or 2. Cramp synchronized movement that becomes predominant or consistent, seen before 43 weeks post-menstrual age, would have less favorable outcomes for ambulation, as they likely develop a GMFCS level 3 to 5. So using the trajectory tracking in combination with tracking the weeks, you would be able to determine potential diagnosis, but also based on that diagnosis, you would be able to determine potential GMFCS level based on those studies. Motor repertoire of infants 3 to 5 months consists not only of fidgety movement, but also movements like anti-gravity movements to midline, leg lifts, swiping, etc. Like you saw in that video of the typical fidgety, they were beginning to lift their legs against gravity, bring their arms to midline, and then the fidgety movement was the background movement. A more advanced form of the general movement assessment looks more closely at these anti-gravity movements and more voluntary movements, and attempt to qualify and the quality in order to create what's called an optimality score based on the findings. So, a 2019 study by Spieler et al. Found that there is an association between the motor optimality scores and the GMFCS outcomes. The study suggests that a motor optimality score that was greater than 14 was most likely associated with the GMFCS levels 1 or 2, which means that they had more favorable outcomes for ambulation. The study also suggested that motor optimality scores less than 8 were associated more with GMFCS levels 4 and 5, meaning that their outcomes for ambulation were less likely. The study also supports early intervention for those with optimality scores less than or equal to 14, who also present with absent fidgety, whether the absent fidgety be persistent or inconsistent, in order to promote neuroplastic changes early on and capture them during those critical periods. So, aside from components of the general movement assessment, atypical movement patterns can also be used to assist with predicting prognosis for ambulation and other motor outcomes. The same study by Spieler et al. Looked into different atypical movements for those children who had poor independent mobility later. And they characterized these atypical movements by atypical age-specific motor repertoire. So the study found that an atypical mouth movement, in the article it's described as repetitive opening and closing of the mouth, was associated with a GMFCS level 3 to 5, as well as bilateral cerebral palsy. Atypical arching, atypical foot contact, which is described in the article as dorsum to dorsum foot contact, were also associated with GMFCS level 3 to 5 and bilateral cerebral palsy. Atypical visual exploration, the article specifies more strabismus visual impairments. Atypical head postures and lack of variable finger postures, which we typically see in the clinic. For those with CP, it would be consistent fisting. These are associated as well with GMFCS level 3 to 5. Asymmetry of segmental movement was found to have associations with a GMFCS level 1 or 2 and a hemiplegia diagnosis. So these ones tend to be more favorable than the other atypical movements that are described on this slide. Circular arm movements were also associated with a GMFCS level 3 to 5. It is also associated with bilateral cerebral palsy and non-spastic forms of cerebral palsy, such as the dyskinetic forms. So, a study by Wu et al. Looked at gross motor milestones in terms of prognostic capabilities for ambulation in children with cerebral palsy. This study found that the majority of children with a GMFCS level 1 or 2 will take 10 unsupported steps, whereas half of those with a GMFCS level 3 to 5 will do the same. The study found that the child's GMFCS level within the first year is predictive of walking capabilities later on, around 6 to 12 years old. The ability to sit independently by 2 years old was the strongest predictor of ambulation found in the study. So that is kind of the goal that you're working towards if you have a child with a CP diagnosis early on. However, if a child is not also pulling to stand at that time, then the walking probability drops to 50%, and that is walking with or without support. If a child was sitting and pulling to stand by 2 years old, 76% of those children were found to be able to walk with or without support by the age of 6. So looking at typical motor movements that you would see in a typical infant, so rolling, sitting, pulling to stand, and trying to get those in before 2 would give you a better prognosis for walking later on. So what does this mean in terms of intervention focus for children with cerebral palsy? If we look at ambulation in those with CP in terms of the ICF framework, we could evaluate how walking affects the overall participation. So a study entitled Walking Ability, Participation, and Quality of Life in Children with Spastic Diplegic CP found that a 1 standard deviation increase in the walking ability of that child increases social participation by 81%. And then a 1 standard deviation increase in overall participation was associated with a 0.85 standard deviation increase in the quality of life. And this can be huge for families. So if you work towards independent walking, whether that be assisted or unassisted, Their overall social participation improves and their quality of life improves. Sometimes for those that are more limited, you might have something clinically like depression, anxiety. So increasing their ability to participate in social activities can help negate those. The same study looked up factors affecting walking and found that muscle strength, balance, selective movement, and spasticity were all body structures and functions that affect ambulation the most. Out of all of those listed, muscle strength was found to be the most important factor directly affecting walking. So a 1 standard deviation increase in muscle strength resulted in a 0.447 standard deviation increase in the ability to stand and walk. So increasing overall muscle strength helps with walking because it also indirectly influences their ability to balance themselves. It affects their range of motion overall, and it would affect their BMI. So all of those factors are also indirectly influenced by the child's muscle strength. Balance was the second most important factor when discussing walking. So a patient with a favorable GMFCS level, whether that be 1, 2, or 3, would show acceptable functional balance, whereas children with level 4 and 5 showed deficits in balance and postural control more so than those with the lower GMFCS levels. The study by Van Gambi et al. Found that a 1 standard deviation increase in balance could increase walking ability by 0.326 standard deviation. So again, improving a child's balance, even just by 1 standard deviation, could help with their prognosis later on for walking. In terms of spasticity, a 1 standard deviation increase in spasticity will lead to a 0.143 standard deviation decrease in walking ability. So this is because the spasticity, if it's increased, it decreases the range of motion of the hip abductors, knee extensors, dorsiflexors, all of which are needed to produce efficient gait patterns. So the more spasticity that you may see, the less efficient their gait becomes, and it just becomes harder to maintain those gait patterns. So overall, when we're looking at body structures and function, we would want to increase the muscle strength, increase balance, increase selective motor control, but we would want to maintain or decrease the spasticity in order to promote an increased prognosis for walking. For the activity level of the ICF framework, we should consider the ability to, like we said earlier, sit and pull to stand, and as well as rolling was also included in that study previously. A patient who is capable of sitting and pulling to stand by 2, as well as rolling by 2, have a greater increased likelihood that they will ambulate with or without supports. A study by Bengochi et al. Found that measuring functional strength and dynamic postural control during a sit-to-stand was the only significant predictor in the study of taking 3+ steps independently. So therefore, if you want to add a sit-to-stand assessment, whether that be the 5 times sit-to-stand and you're, evaluating their control, doing that kind of strength test, you would be able to determine the likelihood that they would be able to stand. But the sit-to-stand is also a great assessment of just overall dynamic control, especially during transitions. So you would be able to determine any sort of postural impairment or impairment in overall balance and control that would affect their ambulation potential later on. For environmental and personal factors, we would want to evaluate the access to care and care coordination, as well as intrinsic motivations to perform walking at any level, whether that be with support or without support. An article published by the American Academy of Pediatrics entitled Providing a Primary Care Medical Home for Children and Youth with Cerebral Palsy outlined suggested care coordination for the population to better ensure appropriate treatments and monitoring of prognosis. The article is quite lengthy, but they also have like a summary article that you can read if you're interested. This article suggests that primary care physicians who provide care for children, so any primary care who will see children or pediatricians, must be familiar with the definition, the manifestation, and the management of cerebral palsy. Those physicians who see children, so those who this article would be applicable for, they should also recognize infants who have a greater likelihood of CP, so they should be able to recognize the risk factors that we discussed at the beginning of the presentation, and based on those, create a monitoring plan for surveillance, as well as referrals to appropriate specialists and therapies overall, in order to capture the children within those optimal neuroplastic periods. Clinically, we do see variability in the environmental personal factors. We see some families who have great access to care and care coordination, and others who are not so privileged. They might have difficulty getting to appointments. They might have difficulty paying for gas for their cars, things like that. So trying to create a system where everyone can access the care and care coordination that they would need is kind of what the study is looking at. And then for intrinsic motivation overall, that's always a personal factor no matter what diagnosis you're looking at. But for children who might not have intrinsic motivation or even cognition level to participate or want to move, it is harder to attain walking goals than those who want to keep up with their peers, and for those who want to make sure that they're walking in schools. For those who have the intrinsic motivation, sometimes it's not every setting, like we discussed before. Sometimes it's just in school they want to walk. Sometimes it's, just at home they want to walk because it's not as far distances, and that's okay. The more that you can promote the walking in patients with cerebral palsy at any level of independence or any distance is helpful in maintaining overall function later on in life. So I think that's it. Any questions?
So if you do have any questions, feel free to either type it into the chat or unmute yourself and ask. So I have a question about motivation. So
Yes.
You obviously showed there's a significant difference between environments.
Yes. Yep.
How do you, as a pediatric physical therapist, either use that to your advantage or help the child? Obviously you can't provide internal motivation, but how do you provide external motivation?
Yes. So right now, for example, I have a patient with cerebral palsy. She's older. So she would be considered GMFCS level 3. So her motivation to walk out in public has decreased significantly because she can't keep up with her peers when she's out in the mall and things like that. So we did work to get her a wheelchair, but she is motivated to walk in school because the wheelchair is too cumbersome. So working on trying to convince her that, she can walk even if it's just short distances at home or school is kind of what the goal would be, and kind of meeting them in the middle. For some patients, she's pretty stubborn, but for some patients you could do motivational interviewing strategies and create that intrinsic control and intrinsic motivation in them. Others just aren't as willing to do that, and that's okay. Sometimes you just have to meet them where they're at. But for those that you are able to use the motivational interviewing and create that, try to trying to create that intrinsic motivation early on. Usually I try to implement those strategies for motivational interviewing in the evaluation. So asking them what they want to be able to do, asking them what's hard, making it seem like it's their idea that they want to walk more, those kind of things. So certain questions that you can ask. I usually say, is there anything that's hard for you? Is there anything you wish you were able to do? What's limiting you from doing that? How have you been working on that at home? How do you want to work on that here? Making it more compliant for them and making it more goal-centered so that they get the most out of the therapies.
Cool. Thank you.
Yep.
And I actually do have another question.
Okay.
You mentioned earlier on that, if you track the child's classification,
yes,
it's important to evaluate them multiple times.
Yes.
If somebody's not coming to you regularly for intensive care,
yes,
how often would you suggest that the parents try to get them in? Like, is it every year?
Every year.
Every year.
Yeah.
Okay.
So we will redo. Those levels are based on the GMFM, and we typically repeat the GMFM annually to determine if there's any change or any goals met, because you create goal areas based on the GMFM. So we typically will do it annually. And usually for those that don't have consistent care, or like were discharged, I will have them follow up in 6 months to a year just to like monitor certain areas.
Okay.
Yep.
And you find that when you're seeing them more frequently, you're able to catch things quicker?
Absolutely, yeah. So you're able to determine different goal levels that they're starting to hit, and then you can progress their home exercises from there. They don't all necessarily need consistent therapy, even with those check-ins. Sometimes, especially if they're a higher level, like a GMFCS1, you can kind of get away with a home exercise program and follow up again in 6 months.
Awesome.
Yeah.
Well, thank you very much.
You're welcome.
If anybody else does have any questions, please feel free to email Dr. Carnell or myself, and I will get the question to her as quickly as I can. Thank you very much, and we will see you for the next grand rounds. Make sure you take your quiz and your course evaluation. Take care.